ألو.
Yes,
أستاذ تسمعني مو؟
that's my problem. Good evening, everyone. Today we will continue our PGI series with Dr. Mahmood Shihab, and today it's about the diagnostic tool of periprosthetic joint infection and some revision of the notes about the previous lectures. Dr. Mahmood Shihab, you have the mic. Thank you very much.
Yeah. Hello. Thank you very much for all of you. Please let me know. Do you hearing now?
Yeah.
Okay. Yes. Let me say sorry for this technical error, and it's usual sometime in error. Welcome to all my colleagues, actually, all to the student and all the visitor guests from outside Iraq. As we know, we have a series of lecture, one of the most important complication for those working in knee replacement, which is PJI and SSI. And as you know, in international consensus meeting, which carried in Philadelphia, it has 3 sections: section for prophylaxis prevention, then section for diagnosis, then section for treatment. And this recommendation is actually done or achieved according to tens or hundreds of literatures. So everything in this literature with the document and voting in this result. We talk multiple series. I think this is 5 lectures in prevention and prophylaxis. In a second part of this review will be in very important subject, which is how you diagnose PJI. So just I will go to some review for my colleagues that not attend and skip some important information. Just highlight on them. We talk about many when we talk about prevention, we start about the factors of the which affect PGI. Just 1 minute, Dr. Sina.
Yes, sir.
So we talk about the host factor which causes biofilm and infection. Regarding the host factors, we concentrate about the importance of screening of the nose for Staph aureus, and we talked about the drugs which is better as a prophylactic measure and prevention PGI, anti-rheumatoid or glucocorticoid or anticoagulant, when stop it and when to start after the surgery. And we talked about the disease which has a risk factor like diabetes or rheumatoid arthritis, that it needs some measure before the surgery. And we talk about the skin preparation prior to surgery. Then in the second part, we talked about antibiotics, about duration and when to give it, and where to extended doses or single dose, then and risk factor, primary and revision. As surgeons who are working in this field, we may face the situation that patient present to you in your clinic, outpatient in the hospital with different type of stage of PJI. And this is actually, in your field, you face these cases. And as we're told, as a surgeon in this subject, don't afraid, don't escape from this complication, to open the door and face it. And you can solve it also by principles. So our aim, to have plan to get the trip, check everything, prevention, prophylaxis, preoperative measure, intraoperative measure, so your surgery will be correct, suspected, and without any complication, with no complication and no morbidity. We talk about the very important subject about the biofilm, how it forms by attachment, by the bacteria, by the attachment and adhesion and aggregation, then separation going to cause more infection. And we talk what's the importance of biofilm, because it is a natural phenomenon, as we say, in the rocks near the river, but the important, it is causes foreign body infection, and because of using in moderate medicine a lot of arthroplasties and plates, so this biofilm stick to the foreign body and cause foreign body infection, and this is would lead to pre-prosthetic joint infection. When there is infection, the management is surgically. This is our responsibility. Surgery and with additive antibiotic according to the germ. And then we talk what's the intraoperative measure to prophylact and prevent PJI regarding the how we can use fluids or antiseptic for colonization of the bacteria, and when it is used better for, before 48 hours. And we talked about the irrigation of the wound by betadine and saline, 70 cc sterile betadine with 500 normal saline. The advantage of using antibiotic-loaded bone cement and the phenomena of bulk diffusion or surface phenomena, that how the antibiotic in the bone cement comes to the synovial fluid within the first hour, it will be in high concentration. We talk about the mixing of the bone cement. The goal is to get homogeneous by vacuum better than manual. What's the side effect of the antibiotic in the bone cement? Ototoxicity or nephrotoxicity. We talk about it and how get the perfect level by measuring the renal and other measures in the blood. A lot of discussion in Philadelphia regarding international consensus will come and voting by 800 surgeons. And we actually, fortunately, we have 2 surgeons from Iraq for 3-4 days about this recommendation. And we talk about the rule of the using antibiotic in the bone cement. So the most important recommendation in ICM, you can use bone cement without antibiotic if concentration of the cause and toxicity of the antibiotic which present. So in primary total hip, primary total knee, it is not mandatory to use bone cement with antibiotic. And then we talk about how the wound closure and surgical dressing of our joint arthroplasty to prevent PJI. We talk about the phases of the wound healing and our goal for wound closure regarding the capsule and subcutaneous and the skin. In skin, we need osmosis. Regarding the arthrotomy and subcutaneous, we need strength and bioburden reduction. And what's about wound perfusion? Whenever the oxygen intention is high, the infection will be less. More perfusion, more blood at the area, this means infection is less. And we talk which area is more tension, especially inflection. We talk about the P1 proximal part, and suprapatellar part is the most part which is under tension, especially in 50-degree inflection. Also distal part, infrapole of the patella, there'll be under tension in flexion to be taken in consideration. So, and we talk about the strength of the suture you're using and how these sutures lose their power and which is better. And if you see Dixon and non-absorbable, they lose their power after 4 weeks, and it is better than silk and pluglyctin. This is to take in consideration when you are suturing the wound. And we talk about what is the benefit, continuous versus interrupted. Continuous, we say, it's better in every manner, just can compromise when there is infection, you must open all the suture. But regarding other factor, in fluid migration, tension across incision, less time, less foreign material because there is no knot. That's why continuous is better than interrupted. And about the skin incision perfusion, the continuous one is better than interrupted and then better than staple, has more perfusion. So it is less PJI. And then we talk about the barbed knotless stitcher and its benefit because optimized to the patient, because tight, watertight closure, and it's a surgery, of course, and no staple you can use. Tranexamic acid, you can use it with the good dose without migration from the arthrotomy to outside. And of course, you're going to low dose of anticoagulant. And this is advantage of the knotless suture. What is the benefit of tranexamic acid now, which are using 1 gram IV preoperative and 3 gram with 35 cc of saline intraoperatively, and when you after finishing the arthrotomy, we say better to flex the knee about 70 degrees that the suturing will be. There is controversy about section drain to be used or not to be used, and talked about the literature. And what's about the surgical dressing management? And we talk, what is the surgical? It is a barrier that from the bacteria not coming from the dams contaminate the wound, especially 48 hours. So there is a strong relation between SSI and PJI, especially in early wound closure. There is open remarks about that, which type of dressing you are using, and how often should be changed, and what to do in case of discharge. And we talked about what type of dressing. We have passive, which is protective, active, which there is moist with it, addition with protective, and we talk about the interactive, which is vac, would have additional aim. And there is we talk about the classic versus that Confiel and other Aquacel dressing regarding to reducing PGI. And what's about the checking the wound? We talk about errors in our tradition to follow the wound and to open to the wound, to check the wound. And this is, we say, this is error to be better is not to be done. And how often should be dressing to be changed? It's better to be first 48 hours, no change of the dressing, and keep it dry. And one of the recommendation in ICM is possible, never open the dressing which you did it in the theater. So this means after 2 weeks, you can change it and going to remove the suture whenever you can come. How long the wound should be recovered? We talk about the shower, and you can after 48 hour you can take the shower without afraid of any PJI. Then we talk about the last point, which is the discharge, and talked about the duration and amount of the discharge. Then we go in detail in what is the definition of prolonged discharge or copious discharge, and what is definition of persistent wound drainage. Which wound we can say this is persistent wound drainage if became drained more than 72 hours, according to the recommendation of ICM. What is the advices? What is not to be done? Swab is never taken from the wound discharge, and never to be antibiotic to the patient. These two things, it's better to avoid it. If you have discharge, so what you have, your option, either pharmacological to reduce the molecular weight anticoagulant, or mechanical, we stop the physiotherapy, or we take wound care. Sometimes we use a VAC system, or the continuous drainage. There will be to DARE, which is debridement, antibiotic, implant rotation. This is the مختصر يعني what's mean there. And what we talk about the wound discharge and the amount, if it is below 2/3, it's better not change it. If it is more, you can go to change it. And if it is continuous from 3 to 5 days, we use VAC system, which is indication for prophylactic and therapeutic. And so we get some algorithm for the wound management. If there is wound drainage, first 3 days, observe the amount of it. It is less than 2 or 3, no change. If it's more, change it. If continuous the drainage, 5 to 7 days, go to the VAC. If it is continuous more than that, go to surgical management. So wound drainage, continuous to 7 days, it is for DARE. And the home message, for we talk about that, occlusive dressing to be applied with moist, but not excessive. And it's better not change the dressing, all if needed. Quick action if there is discharge, VAC one of the option, surgical action if it is continuous. So now we start the second important subject, and regarding how you define that this is infection or not, prosthetic joint infection. As we know, the most undesirable complication is infection for all my colleagues working in this subject. And this is some of the cases you may face it in every step, from the mild to moderate, severe, implant outside. So why we are talking about the diagnosis? Because there is significant number of undetected infection. We cannot detect the occult infection in aseptic joint loosening is about 10 to 20. So 10–20% they have occult infection, and we have no idea about that. And there is literature, there is high number that the surgery which caring for aseptic revision is actually a septic revision. So occult infection and cases of aseptic is actually, it is septic. As we know from the ICM, starting from the prophylaxis, prevention, antibiotic treatment, a big question mark for the diagnosis. This is very important to get the diagnosis, and all of us hate and not want or have desire. This is infection. And always we treat it by antibiotic. No, this is not infection, but actually maybe this is occult infection. May I ask a question? If you look to these x-rays and the wounds, I ask one question: which is infected, which is not infected? No one can answer this is infected just from looking to the x-ray and the skin. And all these cases actually it is infected. What are the conditions that let you cautious and think, turn you into a detective investigation pre-prosthetic infection? What is remarks that you see it, then you are thinking about the infection. When you see loosening of the total joint within first year, when you see in the x-ray something loosening, think about the infection. When you are seeing elevated C-reactive protein, when there is unspecific symptoms by the patient, night sweating, unwanted loss of weight, or fatigue, or fever. And the most important is when the patient presents to you by unexplained pain. These conditions let you to think the patient may have infection. In ICM, as I told you, there is one complete session about how you diagnose PJI. And why we getting this progress and investigation in PJI and diagnostic tools to get sure that this is PJI. There's one case I will present you in serious and a strange case. So by story, we go step by step. This is a case of lady, female, 79 years old, with BMI 120. Has simple intercondylar fracture, orifice done, 2010. And infected with loosening, they did for her hinge. Seems to be there is ligament instability or there is bone loss. This lady also had right primary total hip replacement for avascular necrosis in 2012. For the right hip, they did for her there the antibiotic and implant rotation because there is early PJI. So they did for her primary total hip avascular, and there is there because they regard this acute PJI. At the same time, the lady have 3 irrigation and drainage of the left shoulder infection due to septic arthritis. In 2015, the patient represent also massive pain of the hip and the knee. And there is no local signs of infection and there is no fever. Just CRP within the normal range. First question was in the ICM. What clinical findings, fever, erythema, reduced range of motion, are most sensitive and specific for diagnosis of GI? And if you saw this analysis randomized for and risk factor 35, that they say there is all the of sign and symptoms. They are sensitive, but they are not specific. So the recommendation at that time was a painful prosthetic joint is the most sensitive one, but it is not a specific clinical finding. You cannot depend on it. The signs of deep tissue involvement when there is sinus tract, purulence, abscess, and extensive necrosis are the most specific sign. It is important to note that clinical findings differ notably based on the type of the joint involved, hip or knee, as well as timing and presentation of PJI. And this is agreed about 97. So a painful prosthetic, it is sensitive, but not specific for the PJI. Let's go to our case. Our patient has no local sign of infection, and there is no fever, and the CRP normal. So the next question arises: does the presence of an ESR and CRP below the PJI threshold rule out the diagnosis of PJI? Okay, this patient has normal CRP. Just this number, we regard that we got rule the diagnosis of the PJI. If it is normal, ESR, CRP, and about the literature, meta-analysis, everything, and the recommendation, they 100% agreed serum ESR and seroactive levels below the threshold determined by MSIS, Multiskeletal Infection Society, before there is ICM. They not exclude the diagnosis of pre-prosthetic joint infection. This is very important for when you send the patient for ESR, CRP, if it is normal, this is not rule the diagnosis of the PJI. Because serum levels of ESR and CRP can be normal. And this is 100% is agreed. Recommended that normal ESR and CRP not exclude infection. By this, that's why we return back to MSIS, Multiskeletal Infection System Algorithm, 2011. They concentrate about the CRP and say, and depend on that, if it is CRP is normal, this is rule there is no infection. And this is one of the conflict between MSSIs in 2011 and 2018. They depend highly on CRP. If it is normal, this is not infection. So what's other diagnostic tool? ESR and CRP, they are normal with this patient. Are there is any contraindication to knee or hip aspiration prior to the surgery? This is for the hip and for the knee aspiration, that the patient have total knee replacement. There's contraindication to aspirate. The recommendation, there are no clearly identified contraindication to aspiration of the knee. So you can aspirate more diagnostic tool that ESR, CRP normal, and you still doubt of the infection. So please go to aspirate. It's high agree, it's about 90%. So another question, if we can, by sometime we do aspiration, there is tri-tap, not coming fluid from the joint. You try many times, there's no fluid. One of the suggestions that you levite fluid you saline introduced to the joint, then aspirate. So one of the questions in the setting of dry time, one stage or two stage reimplantation, what is the recommendation? Purulence is subjective measure which can be present in aseptic condition, and the recommendation was intraoperative purulence should not be considered as a definite sign of PJI, and it's about agreement of 75. Why this no considers as this is PJI? Look, every procedure we are doing that we want to get the diagnosis. When you aspirate pus, this is not definite diagnosis, this is infection, and go to the second step. Because sometimes there is metal to metal and polythene wear, metal losses. There is pus, but this pus is sterile. This is not infection. And metal to metal, there is sometimes using, especially in the head. That's why these cases causes abscess or pus, but this is sterile. So in the second aspiration, serum was normal, but in the white BC count is 10,000. As we know, till 3,000 we regard it normal. And polymorph, it is 98. As we know, till 70% we regard normal. Alpha defensine was high. Leukocyte esterase not done because it's hematogenous. And the culture was no germ. And me, it's normal aspiration, no pus, and clinical no pus there. And culture is negative. So at the last, the definition, MSIS, multiple musculoskeletal infection social, 2011. What are the definition of the PJI? All this lecture, we want to go, what's the definition of the PJI? The old definition, they say 2 major criteria and 4 minor criteria. 2 major criteria, this is, we have no problem and no dialogue. When there is sinus tract communicating with the prosthesis, this is infection. Please, you diagnose and continue your plan. And if you aspirate and positive culture in 2 separate tissue or fluid sample, this is 2 positive culture, this is also infection. This is the major criteria. What's about the minor criteria? I am talking about the old one. Serum ESR increase and serum CRP increase. 4 minor criteria. Synovial leukocyte, we depend, synovial neutrophil percentage, and purulence in the affected joint. I am talking on the whole. Positive culture of periprosthetic tissue or fluid. When you take the biopsy, there is positive, and 5 neutrophil for high power. This is the all how they define the periprosthetic joint infection. So this is new definition of musculoskeletal, that the minor, which is serum ESR and serum CRP increase, and synovial leukocyte and synovial neutrophil. This is what we have in our patients, because everything is normal in this patient I present you, except polymorph, CRP normal, synovial leukocyte increase, and synovial neutrophil percentage is increase. So, according to MSIS, this is negative because she has only 2 minor criteria. So, what is then? You are happy this is not affected, and you treat him as aseptic condition, like painful knee, instability, or other cause, you get happy, or there is infection or not. That is the question. Another question which is raised: should intraoperative cultures be taken during every revision? I'm talking to every revision, not septic revision. Total joint arthroplasty, if so, how many? The answer recommendation was yes. Routine culture should be taken during every revision of total joint arthroplasty, and at least 3. Upper culture sample should be obtained. Okay, what's about relation of the number of the biopsies? How many biopsies is mandatory to be taken? One of the literature and experts say there is the infection rate more increase with the more number of biopsies. So 3 is better than 2, 4 is better than 3. So how much you taking the biopsy is better, because the rate of the infection, because sometimes to detect in tibial tissue, not detecting in the femoral tissue, or on the synovium or in the ligaments. So that's why more biopsies will detect more. Okay. What's about the bone? There's another question. Do bone culture provide additional diagnostic when you taking the biopsy? The recommendation, inconclusive. So try to take it from the soft tissue. Biofilm more in the soft tissue. Regarding the bone, the recommendation was inconclusive for the bone. Okay, what's about diagnostic accuracy of histological tests and threshold used in the diagnosis at the time of the operation? The recommendation, there is variability of histological examination. That you are in the surgery, you do for the histology, for the presence like that, there is variability. And they agreed 88. This means they are not depend on much on this investigation, because it is very good rule in test, but it's relatively low value rule out test. So they are not depend high on this type of diagnostic tool. And as we know, for our patient, perioperative and postoperative, histologically, there is no bacterial culture, no bacterial growth, and histologically is nothing there. Another question: if you suspect when a patient undergo a septic region and intraoperative culture grow on organism, should patient be treated antibiotic therapy? Recommendation was not start the antibiotic unless you get 2 specimen positive. If you get 1, no. But if you go 2, 3, this is a tool or a goal that you can give antibiotic. So rule of the when checking the file, or there is germ, at least 2 positive cultures that you can start antibiotics. So for this patient, the open biopsies culture negative, and they regard they do 1 stage total femoral replacement, and intraoperative culture was Staph aureus. So what they did in ICM after 5 years, actually first is 2013, the second is 2018. You look, this is about 32 surgeon and experts from the scientists working in the surgery or lab or biology, biochemistry, everything. They work to get the definition of PJI. What does PJI mean for the hip and the knee? And Parwizi is one of them. So, to get analysis to the literatures and retrospective studies by this group, and Parwizi introduced an update set of criteria, new criteria in their paper 2018. And the advent of new literature and diagnostic test, new diagnostic tool. And they reached, after this searching and literature, this is the new definition. And this is for our surgeon working in the knee field. We must know about this, and we put it in paper, in our mind, in our pocket, whenever we are working in knee arthroplasty. And this is the new criteria, how they put the score, how they get, this is infection, this is not infection, this is inconclusive. Two major criteria stay like the old one, which is two positive growth of same organism in the culture, and when there is sinus tract communicating to the joint. This is the major, but the revolution is in the minor criteria, that serum CRP, D-dimer, ESR elevated. If you observe that serum CRP and D-dimer, they have two score, 2 points. Of course, you have the reference in acute, how will be how much, and in the chronic, how much, and have 2 score. For the elevated serum ESR, just have 1 score. So please, when there is ESR high, this is not very significant, have 1 score. Of course, in acute, have no rule. When you are doing the surgery, first 3-4 months, please, there is no rule. Even the ESR elevated, maybe for other causes. In case of chronic, they take into consideration. What's about synovial white BC or leukocyte esterase or positive alpha defensin? And everything in acute and chronic has special reading and has a 3 score. For the elevated synovial PMN polymorph percentage in acute and chronic has 2 score. Single positive, 2 score. Positive histology, 3 score. Positive intraoperative purulence, 3 score. These criteria in your patient, you collected and combined preoperatively, and postoperative score will be 6 and more, this is infected. If it is 4 to 5, inconclusive. Below 3, it is not affected. By these tests and these phenomena of the sinus, major criteria, and the minor criteria, by this investigation, you get that your diagnosis, and you say this is PJI infection or not. And this actually the investigation is present, and alpha definition and leukosteres, and I will talk something about them, is present, and it is cheap, but there is something regarding the apparatus, but there is in Baghdad, you can do it. Okay. What's the recommendation? What's about the voiding? This is very controversial, and we spent more than 3 hours for 2 days to get this infection. And actually, it was 70%. voided with this new definition of PJI. And this is, you observe elevated synovial, leukocyte esterase positive. This is the new one which is introduces in comparison to the old one. Which other tools we have in our pocket? The important is that G dimer, this is new one. You can get the amounted according to the apparatus, how much, because it have two scores, so, and this is important. And there is one question: what is the diagnostic accuracy and threshold of D dimer in the diagnosis? And the recommendation was at that time by IAOS, which started at that time in 2016 about the D dimer. There is many literature. They observed this is the dimer level. In infection, it will be increased. This is septic revision. If you observe it, it is more. That's why it is significant to measure this D dimer. Recommendation was about 75 because it's new. And the other question, are point of care rapid test? What can rapid test for diagnostic PJI? And yes, there is for the leukocyte esterase and for the alpha defensine measuring. And the recommendation was about 73 for this rapid test. And the significant, if you saw leukocyte esterase, this is a simple strip, like sugar strip, urinary strap, and it is very cheap. And you can use it quickly and easy to carry on. You take the synovial fluid of the patient and put the leukocyte, the strip to the synovial fluid. Look, this is the synovial fluid. This is the strip. You just put it in the synovial fluid. If it is infection, the color will show you this is infection. It has a score 3. So if you added other SR, CRP, polyp or neutrophil, and the differential count, and this is rapid test and cheap, and you get an idea whether this is infected or not infected. Actually, this discovered by Perwiza, and Perwiza advised to use it. And there is a literature when they use it for 50% infected cases, 50 revision, 50 test is positive. That means it is specificity as specificity. And this is the another culture positive. One of the that's encourage this literature for the diagnosis of the PJI by leukocyte esterase. And according to the other lecture, they saw sensitivity and specificity in total and totally it's high percent. And also when they are combining alpha defensine with the strip, they show sensitivity 81 and specificity 97. The last question, what is the role of alpha defensine in the diagnosis of PJI? They say the left research, the alpha defensine has been studied in numerous institutions, both the sensitivity and specificity of the alpha defensine laboratory exceeding 95. So it is a good diagnostic tool for PJI. And measurement, the recommendation, measurement alpha in synovial fluid is a complement to existing diagnosis of PJI. level of is moderate, is about 82. And if you return to our case, if you apply this to our patient, it is infected because she has 9 points. In comparison to the old MSIS, it is just 2 minor and not reached 6. So that's the importance of new tools of diagnosis, because you have other options, which some of them is rapid options to get diagnosis of PJI, then continue to your treatment. Because the most important of surgeon, that when the patient coming with the painful knee, to get an idea this is infection or not infection. And other result done by Parvizi also show the sensitivity 97 and specificity 99 for this. And this is the book which I advise to my colleague to read it. I don't know if you see it, this. Yes, and every information is given to you by this book, and all your document, literature, and how this appeared for all the colleagues that working in this field, whether total hip or total knee replacement, how you get diagnosis this infection. Lastly, I present one of the cases as we use and usual. I have a lady, 70 years old, with bilateral osteoarthritis. She did bilateral total knee in 2016. Right knee started pain with some night sweating and fever. Sorry. They diagnosed it as PJI. She's out of country. So this is mild, simple osteoarthritis present to. I am just seeing this, looking to this mild osteoarthritis, simple, that needs simple surgery, total knee arthroplasty. When you are not aware about the prophylaxis and the prevention prior surgery and in the surgery with the environment and the sun. I'm sorry, we not talk about the environment of the surgery, because the surgeon, the staff is working, the nurse, and the condition of the theater, mask, gloves, everything may lead to infection inside the wound when you start the incision, and the end to the PJI, which is the most undesirable complication. So that's why our aim of our lecture, prophylaxis measure, preventive measure, to be happy, the patient and the surgeon, everything, no infection, and everything is going good. So this is mild osteoarthritis. The lady presented, and they did for her surgery, totally replacement. Yes, this is, if you look, I think this is J&J. I don't know. I have no idea. Okay, for left and right. If you observe the right one, there is imbalance. Seems to be there is something in the surgery, not the left one. Okay, our patient suffer, fortunately, the left one, nothing. For the right one, there is pain and continuous and night fever. Actually, they diagnosed PJI, and I don't know what's their rule. They did all the investigation, and they discovered this is PJI. What did for her? Fixed spacer. And if you look, there is a lot of loss of the bone. And I think there is ligaments instability. So they put stiff, fixed spacers, not mobile spacer. And after maybe 2 or 3 months honeymoon, this time there is the infection subsided as they. This is a surgeon decision. What he did, he osteotomy of the supracondylar lower end of the femur and applied tumor prosthesis, or say mega prosthesis, because it seems to be the epicondyle is gone, ligaments is gone, and all the tissue is maybe infected. And he did wound excision at time would end a big, huge gap. Then he proceed to mega prosthesis, and with it he did osteotomy, tuberculostomy. Why? This is one of the complications of the fixed spacer. Always saying it is stiffness and contracture of the tissue. That sometimes you do the snip, but you this is not enough. You go to tubercular osteotomy. It seemed to be that it's stiff. That's why they did for her osteotomy. But if you observe, the tubercle tuberosity is intra-articular. So they did for her another surgery. Another surgery because the screw was loose and the osteotomy side getting loose. So they did another surgery. They removed the screw and the patella become ultra supra. There is extensor mechanism damage. If you know, this is the osteotomy, and the patellar ligament be short and the ligament become high. So there is danger for the extensor mechanism also. So you have infection, extensor mechanism. And this patient, after the surgery and after the continuum of the infection, he presented like that. And this is the last. After this is the wound. When take the X-ray, this everything is shattered, loosed, patella become high, and there is loosening of the attachment of the cement with the megaprosthesis, and there is a lot of osteolysis and extensor mechanism damaged. So she presented to me, and of course this is PJI, there is sinus, there is no question about this. This is infection. According to the definition of PJI, there is sinus tract, so this is infection. You must go to remove everything. And this is intraoperative findings for the megaprosthesis, and this is from the femoral canal, and we try from the tibia to remove. The most annoying part of this surgery when you remove the cement, because the surgeon used long stem. This means a huge amount of the stem. So you need to do osteotomy and to remove part of the bone cement, not to be even a piece for it in the femoral canal or tibial canal. So we remove everything and complete removal of the. If you look, this is the megaprosthesis, which they use it, and this is the knee after removal. Everything, actually no epicondyle, just part of the femur and the tibia. What I did for her, it is long bone cement with K-wire for the femoral canal and the tibial canal, just for the fixation, because I cannot do telescoping, I cannot do mobile spacer. Just I got by a rod to the femoral canal and tibial canal. And I follow the patient for more than actually 8 months, 10 months, until I reached to this point, CRP negative and ESR 14. So the measures for me now, and everything is clean regarding the skin, and she has no pain, no sign of fever, everything as skin conditioning. And this is, can I apply it to the space for the femur and by K-wire to fix it. And she presented to me for 2 weeks. This is the last condition of the before 2 weeks. Now, what's the plan? And my question to all of my colleagues, what's the next? Amputation, arthrodesis, or tumor prosthesis? So when I do my decision, with pleasure, I will let you know the case and what is the result. Thank you very much. I am very sorry for this interruption.
Oh, it's okay. Thank you very much for this great job. Actually, it was a very interesting and challenging cases. And thank you for your lecture, sir. We have many questions, actually, not some. But before it, I have one thing, sir. First of all, yes. During the investigation, I want something to illuminate about the total hip also. There are some cases with metal on metal, especially in Europe, they use it. And whenever a metal on metal bearing device is used, or there will be a corrosion reaction. So you don't be afraid if you have post-operative polymorphic nuclear cells and the white BC are elevated, especially when you do synovial aspiration, because metal on metal may have a corrosion reaction. So that's why it is not a conclusive for infection. Another thing is that...
yes, just Dr. Sinan.
Yes.
This is actually a permangan, metal to metal femoral, when they do, it is done, and at that time, that's just pseudotumor.
Pseudotumor,
which
yes.
is, yes, pseudotumor infection, yes. But as it is not septic, not is aseptic. Yeah. That's why we are talking, it is not close diagnosis.
Well, I think we have raising hands. So, Dr. Ahmed, I will let you have the mic, or you can write it down. Can you open your mic, Dr. Ahmed Bazoun? I'm asking you to unmute. Okay. And Dr. Isam Azawi.
And Dr. Mahmoud, shukran for this nice presentation and copy for this lecture. Just one question. You تسمعني دكتور محمود؟
ده اسمعك حبيبي دكتور عصام. ده اسمعك. Yes, yes.
Yes. If you said we aspirated the joint and there is pus of the aspiration. What's the meaning of pus? It is what?
Yellow, thick aspiration.
Yes, it
not
is what?
synovial fluid. Thick pus. Because
yes,
metallosis, it is like pus and it's clear. That's why we know regarding the pus is an infection, because sometimes that's why in metallosis, and we have Dr. Assam these cases.
Yes. What's the end result of this pus? It will seek a way to outside for a drain. Yes or no?
Actually, if you diagnose, what is the diagnosis? Other tools. Why this pus?
Wait, there is pus. See?
Yes, and get the other tools to say this is infection or not infection, because
what the end result?
Instability, if the metallosis you do, you regard them in stability. One stage, you remove, you clean, and you get your implant in. Our condition and diagnosis if it is past infection or not. Because if infection, you remove and you put spacer, then go to second stage. This is the significance of the pus. That's do not leave it. And بالعكس روح investigation حتى تعرف. If it is metallosis, one stage, there is no infection. You can do it, remove it, and change it.
Okay, thank you.
Thank you, Dr. Hassan. We have more questions, sir. Dr. Muhammad Jassam, you said if you suspect an indolent infection despite normal ESR and C-reactive protein. I think this is a highlight or a question. Sir, I think you are asking Dr. Muhammad Jassam, if you have a suspicion of infection, does an indolent infection, does it require an ESR and C-reactive protein which are normal?
مو احنا قلنا ودكتور محمد انه ال ASR CRP if it's normal, this is
doesn't
not exclude diagnosis. Yes. So continue with the other tools, aspiration, culture, scented يعني polymorph and fissure, and the culture in agar 5 days and brain heart tissue for 12. Not become happy. This is the normal. That's why, because the patient is still coming to you and knocking your door. Please, I have pain. And from your x-rays, everything is normal. And you are sure you did a perfect job. That's why I present you 6 cases. It's actually in x-ray perfect. But they are all infected. How it's infected? Go to other. Especially for the painful and night pain.
Yes. Okay. Another question from Dr. Habatumu. He said that if we get 2 different organisms in 2 different cultures, how do we interpret this result?
Actually, we'll go to our. We regard this as one for the score because there's not 2 infection. So it's better for this case to repeat the aspiration. Then, shall we get the same organism first? If it is multiple organism, I think there will be multiple antibiotic. And from our lecture in multiple antibiotic, if there is resistant or not resistant, we say what type of antibiotic we go. If we diagnose it as infection and we remove it, and for 6 weeks, according to the germ, multiple germ, we give the type of the antibiotics. So 2, it is not regarding 2 positive. So regarding as an infection, we regard as 1.
Yeah. Okay. Another highlight from Dr. Muhammad Jassam. We can go to aspirate, and you recommend against fluid lavage, and the aspiration gets dry. Result, how many times can we repeat aspiration, and what is the next step if the results are inconclusive regarding the aspiration?
Actually, every 3 weeks to 4 weeks you can go aspiration. There's no limitation for aspiration of the joint. So but dry fluid, why not recommend? Because it causes dilution of the microorganism. That's why it's not conclusive for diagnosis. Dry to put syringe and aspirate, and you can repeat many times. Then until you get the fluid and you get culture for that.
Thank you, sir.
Of course, if the culture is negative, polymorph is not increasing, that means this is not infection. Search for another cause for your painful knee.
Okay, thank you, sir. Dr. Ahmed Latif, He's thankful if the patient has a painful TKA despite normal investigation and restoration of normal biomechanics. Can you explain as a painful total knee syndrome? Because many articles talk about this syndrome, which is about 20%, and we only ensure that the patient has nothing is wrong.
شكرا جزيلا دكتور أحمد. Thank you very much. Painful knee is a big subject, very big subject. So the causes to get, you must start step by step. You know, one of the causes is psychology of the patient. And if you do everything and you are sure there is nothing for your work and there is no infection, do you know what is the cause? It's actually for our surgeon, the bad selection of the patient. Because this patient is suffering, even not doing surgery. That's a patient, that's why we talk, what's patient satisfaction? The patient she wants from you or he wants from you to provide from your surgery, to say this is change happened, to know the satisfaction what's in my mind. I'm sure this we're talking about the painful knee because you do every investigation and you are sure from the mechanical alignment and stability soft tissue and still the return to the perioperative X-ray and see it. This may be, it is not indicated or it is bad cell, and this is your luck for this type of.
Yes.
Thank you very much for this question.
Yeah, thank you, sir. I think the patient satisfaction is one of the most important things preoperatively that should be made, especially in abroad. They have a written consent, but here we can verify and clarify the expectation of each patient of what he will have post-operative pain regarding his range of motion also. And tomorrow we will talk about this during the indication of total knee and the preoperative management. And I hope you will be there, sir.
Okay.
I think Dr. Ahmed Jamil Azawi, you want to ask something? He raised his hands. So please, the mic is yours, Dr. Ahmed.
Yes, thank you, Doctor. Thank you, Dr. Mahmoud. This is a very big subject and very nice presentation and very nice lecture.
شكرا أستاذ أحمد. شكرا أستاذ أحمد.
حبيبي دكتور. I want to answer your last question about this poor lady with the rheumatoid arthritis and multiple surgery and infection and loosening and. Really, it is. I think she is not ready to do another operation, and to may have another infection. Isn't with me? You are with me. So yes. I think arthrodesis is best choice to buy bone transport, and that's it.
Believe me, I told her. I gave her
yes.
the idea of arthrodesis. I gave her even the amputation. She said
no. Amputation is very big decision.
Well, she has 7-8 surgeries. يعني لا يعني orthosis نسوي لها أطراف صناعية ذكية يعني
yes.
smart.
Yes.
She refused and she waiting for tumor prosthesis. I will show you when we do it.
Let's get to decide. Thank you. Inshallah. Thank you very much. Thank you. Yeah, hello. Nice to meet you.
Okay, we have many questions again. One of surgeons suggested if the collaterals were infected during debridement of infection of knee, do you advise to excise it or not?
But سنان ipsilateral?
أستاذ هو بيسأل he's asking about during, for example, a first stage revision, and you saw that, and you have the MCL and LCL, both of them are severely debrided and extensively infected.
Damaged.
Yeah, damaged. So
okay.
Do you advise to excise them and replace them again after the second stage, or not? You keep them?
One thing, the idea of first stage to remove all the biofilms. Whatever tissue is affected, if it is M cell, L cell is affected, I will remove it.
Yes.
So the idea to remove all the dashed or macerated tissue. If it is not affected, no, I will keep it, because you know the ligament is very important for my decision for second setting. The first goal to remove all the dead tissue. So I have, even for both MCL, LCL, I can do it, wound excision and the first surgery is very important to do aggressive wound debridement.
Yes, of course. Dr. Mohammed Jassam, again, he is clarifying his question, which was, we can go for aspiration and you recommend against the fluid lavage, and the aspiration gets dry result. How many times can we repeat aspiration? I think Dr. Mahmood, he's told us about the repetition of aspiration until the last negative results.
Lavage, no, not on my decision. ICM.
Yeah, okay.
Void against dry because cause dilution of the fluid and germ.
And Dr. Mohammed Jassam, if you have to clarify your question again, please, the mic is yours.
Just you can do multiple aspiration, 2 weeks, 3 yes, every 2 weeks till you get the fluid and you get the culture.
Yes. Another question is that the second question, another question. According to your experience, sir, what is the most common site of knee infection? Site of knee infection, okay.
Actually, the loosening is more in the tibia.
Yeah.
Tibia. So tibial, around the tibia tissue, soft tissue, is more infected than the femur. Maybe it's standing, more weight bearing, or small tibial plane. Femur is less, but not the bone, please. Soft tissue. Yes, that's why the bone biopsy is not recommended. I always take five biopsy from the synovium and capsule, MCL, LCL, and from the tibium. I take 5 biopsy and do 5 again. This is for 5 days, and brain heart tissue for 15 days for diagnosis the germ.
Yes, sir.
And the most common germ is staph aureus.
Okay. We have another question. What is the role of imaging for diagnostic of infection, like an X-ray, CT scan, and MRI?
I told you what is the condition, highlighted you to think about the infection. When there is loosening and osteolysis, you think about the infection. So X-ray, it is not a diagnostic tool, but it is a guider for you to exclude the infection. Maybe osteolysis for the bone spin, cracking in the bone spin, or the metals, metal loss, something. But when there is loosening or osteolysis, please first, this is guide you and let you think about the infection. If the infection is excluded, think for other causes of the loosening.
Okay. Another question from Dr. Mohammed Jassam. He said that, can alpha deficient replace the need of culture and sensitivity test?
No, it is actually score. If you collect 6 without alpha deficient, okay, go ahead. This is infection. If you're not, you do others. And leukocytosis is simple test. alpha deficient أنا بس أريد أعرف أنه موجود هذا الجهاز. إحنا بمدينة الطب حاولنا ندخلها إن شاء الله.
بس مثلا نو بيوشور هو نفسه.
تيست يفيد ورخيص.
Yes.
يسهل أمرك. That this make your work easy.
It is the same of synovial sure, right, sir?
Synovial sure.
In Zimmer.
Yes.
Yes.
Synovial sure for Zimmer. I am
Yes.
talking from other synovial sure is something is expensive. It's why about $500.
It's very expensive. Yes.
Yes.
Okay. Another question is asked by Dr. Habatumu. Have you ever came across tuberculosis infection in periprosthetic joint infection, sir?
Yes.
Yeah.
I have one case actually, and also I did foreign culture, everything, and I gave him anti-tuberculosis for 1 year, and everything is all right with the patient, but actually recur after 4 years, and same TB. So we regard the TB as the germ, also in the ICM, but the period of the antibiotic at least 9 months, not for 6 to 8 weeks.
Yes.
So there is, yes, and there is fungal also. Fungal is more severe than, you give amphotericin. Yes, fungal is more severe than TB.
Yes, okay. Well, I think that's all what we have. And thank you very much, Dr. Mahmood Shihab, for this nice lecture.
نعتذر على الانتربشن.
We are very sorry for these interruptions. Yeah, thank you, sir. Okay, we will be next in the evening at 9 p.m. According to Baghdad time at Saturday for the second lecture, second webinar of total hip arthroplasty principles. And the lecture will be about the indication and the preoperative management for total knee arthroplasty. Thank you very much and have a nice day.
Thank you.
Thank you, sir. Thank you very much, sir.